Hello, my name is Taylor Chatwin. This is the lung exam, and the date is October 13th, 2025. This is my patient for this exam. They are going to be gowned with the gown open to the back, and they are going to be sitting. To begin this exam, I'm going to start by taking her radial pulse, and I'm going to actually have her put her other hand on her stomach. I'm going to be observing for respirations. We are looking for rate, rhythm, and amplitude. Something that could change the rate of respirations could be tachypnea. Something that could change the rhythm would be something like Cheyne-Stokes, which is after a stroke. And something that could affect the amplitude would be something like hyperventilation caused by anxiety. Next, I'm going to be inspecting the bony thorax. So I'm going to be looking at her back visually, and I'm going to be looking at her chest. I'm going to ask her to shield because she's in a gown. So I'm visually looking at the bony thorax. We're looking for something like barrel chest, which is common with COPD, or something like scoliosis, which is a congenital abnormality. Next, I'm going to be observing for masses, rashes, lesions, or scarring. Again, I'm going to be observing the back, and I'm going to be observing the front, asking her to shield. A common cause of a rash on the thorax could be something like shingles caused by herpes zoster, and a common, or not necessarily common, but a mass that could be found is a Virchow's node, and it is a correlation with GI cancer. Finally, I'm going to be observing the accessory muscles, so her sternocleidomastoid and her scalenes. We're looking at if they're doing extra work during inspiration or expiration. Common cause of that could be something like emphysema, which is the pink puffer diagnosis. Next, we are going to be going into palpation. So I'm going to let my patient know I'm going to be feeling different areas on your back and your chest. And during those times, if there's anything that's painful or hurts, just let me know. So we're going to be going down that, or if it's hypersensitive. So 4 areas on the back, 1, 2, 3, 4, and then we have 3 on the front. We're gonna go 1, 2, 3. If any of those palpations were uncomfortable or hurt, this could indicate a chest wall issue. Next, we're going to be palpating for expansion. So I'm going to be finding her T10, making a W on her back, and we are going to have her take a deep breath in and a deep breath out. Normal expansion is 2 to 5 inches. If there is a lag on either side, this could indicate pathology. An example of this could be a pleural effusion. Next, we're going to feel for tactile fremitus. So each time the patient breathes in or doesn't breathe in and out, each time I feel on her back, I'm going to have her say 99, and the same with her chest. So we're going to do it.
99, 99, 99, 99.
Great, and then we're going to have you shield.
99, 99, 99.
So an increased tactile fremitus could be caused by something like consolidation, and a decreased tactile fremitus could be caused by atelectasis. Next, I'm going to be doing and palpating for tracheal deviation. So we are going to have the patient, I'm going to have her look to her left. We're finding her sternocleidomastoid. I'm going to put the first digit there. I'm going to have her look to the right. I'm going to use my third digit and put my third digit there. And then we're going to have her look forward, and we're going to trace down to make sure that there is no deviation. Sorry, I want you guys to see that, but I also don't want to be in the camera. So we're going to go directly down, make sure that there's no tracheal deviation. Something that could cause ipsilateral tracheal deviation would be something like atelectasis. Something that could cause contralateral tracheal deviation would be something like pleural effusion. So basically a space occupying issue, or something like a tumor. So that is going to be all of our palpation. Next, we are going to go into percussion. So we're listening for the resonance of the lung sounds. So I am going to be tapping on your back. There's going to be 14 areas on the back, and then there is going to be 12 areas on the front. So we are going to do that now. $14 on the back. I'm going to have you shield for me. We're going to do 12 on the front. All right. Something that, if it's a dull sound, that could be caused by consolidation. So that means there's more fluid. If it's hyperresonant, that could mean that there's additional air. So something like a pneumothorax, we might see a hyperresonance. Next, we are going to be going into auscultation of the lung fields. So we're going to be listening to the sounds. There's going to be 14 on the back and 12 on the front. During this time, we are going to hear normal heart or normal lung sounds, and we may hear abnormal sounds. So normal lung sounds are going to be heard over the parenchyma. Those are vestibular lung sounds. Or it's going to be tubular lung sounds, which are going to be heard over the trachea or the bronchioles. Some adventitious hard sounds that we may hear are going to be included wheezing, which would indicate a chronic obstructive pulmonary disease, or something like crackles, which could indicate a pneumonia. As I go with my patient, as I move my stethoscope, I'm going to have her breathe each time I move the stethoscope. If I go too fast at any point, I'm just going to have her tell me to slow down so that we make sure we can get a full breath sound at each point. We're going to be using the diaphragm side of the stethoscope. I would also like to announce that in this specific portion of the test, this stethoscope, the diaphragm of the stethoscope, would typically go directly on the skin. That is going to conclude our lung exam today.